I think there's just the one I haven't received yet, but we'll go through the other one. Oh, who's first? I guess we'll start with the one I got this morning. Dilantin. Okay. Just kind of a tip of what I'm going to be looking for on an exam. If you look at the blueprint, there is 9 neural medications. There are 7, I believe, right? Commercial meds. All of these will be on the exam. Okay. I put on there a comment for our email that it's not just going to be indication of what they are. So if you have Dilantin, knowing that it's for seizures is not good enough. Okay? You have to know the side effects. You have to know what it's for, maybe diagnostics, labs that you might look for. That's kind of the plus of me telling you what meds are on the actual exam. You have to know more about them. Okay? So just because you go through and say, oh, I know what Dilantin is, I know what mannitol is, that's not good enough. So when you look at these commercials, I'll be pulling them from these commercials. You shouldn't have to go do excessive studying in your textbooks or online. Okay? You should be right on these commercials. So we'll start with the first part, following part. That was the first group for Dilantin. I did see a test question in there, so they're not off. That is correct, so make sure you're watching commercials. Dilantin. Okay, we're going to go to the next one. It's not halfway up. We're going to go back. This is the one that you recorded.
Yeah, it might not be the best, but I think you would rather have that one.
You had to record like this so it'd go on. Yes, designer commercials, exactly what I'm looking for. Nice little 2-minute video, 3-minute video. They'll show you what. That one's good. The next one, the back film. This one has a voice over the PowerPoint. I think it's like that.
Suffering from multiple sclerosis? If so, you should talk to your doctor about trying glycerin or acetate, referred to as Copaxone. Copaxone doesn't cure multiple sclerosis, but it can slow the progression of the disease. Copaxone is a protein that works by preventing the immune system from attacking the nerves in the brain and spinal cord. Given subcutaneously, it can cause injection site reactions including pain, redness, soreness, and swelling. Immediately after the injection, some may experience flushing, chest pain, tachycardia, anxiety, shortness of breath, and itching, but it will resolve with time. Other side effects include nausea, chills, joint aches, neck pain, headaches, thrombocytopenia, leukopenia, depression, and suicidal thoughts. Do not take of live virus vaccines, immunosuppressants, and mannitol. If pregnant or breastfeeding, patients should notify a provider immediately. Nursing considerations include educating patients about injection sites, which include arms, abdomen, hips, and thighs. The nurse should also tell the patient to rotate injection sites daily and do not reuse the needles. Patients should notify prescriber immediately if dizziness, hives, profuse sweating, chest pain, difficulty breathing, or severe pain occurs after the injection.
Introducing how to.
Mannitol is our next one. I'm going to add to this commercial because I feel like they might have missed one thing. What labs or diagnostics or nursing considerations do you think that you would look for in mannitol? You can look at intracranial pressure monitoring to make sure you're doing that. What else is it? What is the purpose of that medication? Diuretics, we'll look at eyes and nose, right? Those are things that we can look at right away. If mannitol is working appropriately, what are you going to see changes in your patient? Level of consciousness. If you're having a lot of pressure on the brain and that pressure goes down, their level of consciousness or their neural status will improve, right? So things that you might look for on assessment for your patient. Okay, moving on through. Re-quit. those are all the ones I have so far on YouTube. Some of those two. We're gonna look at the one that Jess just sent me, hoping it works.
And seizures for about 10 years now. How does he gabapentin?
How it is on your computer? What? How it is on your computer?
Well, I haven't played that.
This is what I'm gonna recommend to you. Do what Justine did. Your video that you have, record it on your phone and upload that to YouTube. I mean, not necessarily right now, but maybe by the end of today, so people can see it. I just don't, because I don't know if they're gonna want to listen to it like this.
Well, do you want one?
If you want to like show it right now, we could do that. If you want to email it, or log in, yeah, yep, that would work too. But just so we have like an actual record. Okay.
I mean, I guess we don't.
Also for recording it. Oh, what do you do right now? Why? Right. And then neostigmine, will you guys get that to me by the end of the day? I'll send that link out, or however you guys. Oh, you did? Sorry. Is that why someone crossed out? But then you didn't know? I'll look on my, is that email? Sorry, we get a lot of emails. Okay.
And seizures for about 10 years now. How does he gabapentin? Neurontin.
How long does it take to buffer? What? How long does it take to buffer? The buffer? Dana? Alright, we'll let it load a little bit and we can talk about the, I'll pull up another document here while we're waiting, but.
Oh. That can
What are you contemplating?
you said,
Does it have a lot of words or is it just?
it's words.
Well, that thing should pick up, if you put it right next to there, do that. It picks up sound really well. I say we just try it. Let's just try it, and then if it doesn't work, we can always, you can record it on your phone. It does, but remember, it doesn't record off that device, it records off the desktop. That's the only thing. But if you want to bring your laptop up, we can maybe put it right there.
From uncontrolled nerve pain or ask your doctor about Neurontin. Yeah.
Put it right there. I should be able to fit it. And the sound is more important too, but. I might turn the light off because it might be able to see it better.
Maybe, let me see if I can play that downloaded version.
You might be able to see the lit up version.
Has suffered from seizures for
Looks better. I want to see. Does this help turning another light off?
It's so little.
It is little, but if it plays the sound, it'll be fine. Alright, let's try this. The sound should work. That picks up sound from like
That's your video? Oh,
What?
Okay.
No, that's recording. She's recording it right now.
Okay, got me done.
Turn your volume as loud as it goes.
It is.
Okay.
Wait, you'll hear it in the recording, you think?
I think so, yeah. That little
Okay.
thing picks up really well.
Alright.
Billy Bob, a 40-year-old man, has suffered from seizures for about 10 years now. How do we stop this? He is taking gabapentin, also called Neurontin.
Do you suffer from uncontrolled nerve pain or seizures? Ask your doctor about Neurontin. Neurontin, or gabapentin, is an anti-epileptic and also used for nerve pain, such as diabetic neuropathy. Side effects include dizziness, drowsiness, weakness, tired feeling, nausea, diarrhea, constipation, blurred vision, headache, breast swelling, dry mouth, and loss of balance or coordination. Do not take gabapentin with the following or ask your doctor about concurrent use of alcohol, antihistamines, sleep or anxiety medications, muscle relaxants, narcotic pain relievers, allergy or cough and cold products. Do not use other medications containing gabapentin. Gabapentin may also interfere with lab tests for urine proteins. While on Neurontin, be aware that you will be required for peak and trough levels. Take with food to prevent GI upset and do not take within 2 hours of an antacid. Do not drive or engage in hazardous activities until your response is known. Do not abruptly discontinue drug and do not breastfeed while taking this drug. Notify your physician of increased seizures, visual changes, unusual bleeding, or bruising. Report severe headache, sleepwalking, rash, severe vomiting, chills, fever, or difficulty breathing.
Is gabapentin the med for you? Live a happy life, free of nerve pain and free of seizures. Follow Billy Bob and get to stepping with gabapentin.
That'll be just fine. It's actually good that you recorded your voice. I think that was better than the visual. So I think that'll be just fine.
I have
This is around there too.
I don't know why I didn't pass out though.
Okay, so now. Here.
Yeah, what we're talking about.
We're not frequent. That's basically.
Okay, that's fine.
Yeah. Okay. The reason why is because if for some reason I got in the wrong hands.
Okay.
All right. One last one, and then I think instead of going through those last 25 PowerPoint slides, we're going to review. I don't know if you guys agree with that. I can record those last 20 slides, but there's one question on the last 20 slides, and I feel like you guys can look at that yourself. Does anyone disagree with that? I would rather review because we're getting kind of close to about an hour of time, and I want to spend some time reviewing.
Are we still?
Yes, and I will announce that too after what we're going to do. Just one last question.
Neostigmine, prostaglandin.
I have myasthenia gravis and no medications have worked for me. My eye still droops and sometimes have double vision, and I also have a hard time swallowing.
I'm going to have you try neostigmine. This medication should help with the side effects of myasthenia gravis you are having, and we will reevaluate you in 4 to 6 weeks.
What does this medication do?
Neostigmine, or prostaglandin, is a cholinesterase inhibitor used to control your symptoms from myasthenia gravis. It is also used to prevent and treat postoperative distension and urine retention. While you're on this medication, we will continue to monitor your pace, your respiratory rate, and your blood pressure prior to taking this medication. If you notice any changes in your heart rate, please report that to your care provider. A 10-point test may be used to distinguish between overdose and underdose. If overdose occurs, atropine is the antidote. Atropine or glycopyrrolate should be used prior to or concurrently with neostigmine to prevent or treat for misconduct. This medication is a pregnancy risk category C. You should not use this medication if you have an obstruction of the GI and renal system. Use this medication cautiously in patients who have seizure disorders, hyperthyroidism, peptic ulcer disease, asthma, bradycardia, or hypotension. Neostigmine can cause side effects including excessive parasympathetic stimulation, which is increased GI motility, increased GI secretion, bradycardia, and urinary urgency. It can also cause a cholinergic crisis, excessive parasympathetic stimulation, and respiratory depression. These effects may be treated with atropine and respiratory support. Action may be antagonized by drugs possessing anticholinergic properties, including antihistamine, antidepressants, atropine, haloperidol, phenothiazines, quinidine, and disopyramide. It can prolong action of depolarizing muscle relaxing agents such as succinylcholine or dexamethasone. Finally, a medication that actually helps with my symptoms. It has relieved my eyelid drooping and double vision, improved my chewing, swallowing, arm and leg strength, and my breathing. Thanks to you and your nurse's help with this medication. Disclaimer of endorsement. Reference herein to any specific commercial products, process, or
Make you go through all that.
You know how many times I record my video?
Here's just mortified. I get nothing. Always okay. All right, those should be displayed on there on the recording, so you guys should have access to all those. Okay. If you feel like you didn't get enough visual or listening, I will write them out for you guys, but it should be good for it. Okay, I was going to pull up a document here that's going to give you an idea of how to study for this exam. Obviously, today we're going to go through the blueprint, but we are going to have a review on Sunday at 7 o'clock. I know that these doors are locked on the weekends, so I think what we're going to do is meet down in the lobby, and then we'll just be on our way up. Is there anyone that's going to be late? 7. If you're going to be late, those doors are going to be locked downstairs. You might need to text or call one of us because I can't leave that door propped open or open. And when we leave, we have to make sure everything is the same way we found it because we could get in really big trouble if we violated any of the lab or if we're going to be in here. I'm not sure how many people are coming, but if you do come, we'll be in here or on the other side.
Will you record it?
No, I'm not going to record it. And the reason why is because I actually want people to come. If I record it, no one will come. Okay, and that's kind of the point. I'm doing it for you. This is not a time to reveal secrets about the exam. Okay, if you can't come, don't be too upset. And it's just another thing for helping you guys to remember how to study and making sure that you guys are studying the right things. By this review, you should know 99% of the content. Do not come to this thinking Megan's going to teach more about the exam and this is what I need to pass the test. Okay, by then you should have your study done. Okay, I am going to give some questions, some NCLEX questions out. I will make those presentable after. I will say that, but we are going to go through those in the review. Okay, does that make sense? I'm sorry for people that live out of town. I feel bad, Sarah, but at the same time, if I do that, then no one will come. Okay, and it's not a secret reveal. I don't know what is. Okay. So anyway, what I recommend is starting with your PowerPoints. That's the first thing you should start with. The blueprint should be your study guide once you kind of went over your content. But I do think you should start with the PowerPoints because that's where I pull 90% of my questions. Okay? A lot of those things come from the PowerPoints or what we've talked about in class. As you're going through the PowerPoints, look at your blueprint to see where the most content is covered. If you have 10 questions on CDA and only one on pain control, where are you going to focus more of your study time? Obviously on the one that has more questions. When you're going through your PowerPoints, think about what we did in class, how much time we spent, and what you thought was relevant. If we didn't talk for 20 minutes on a certain thing, it's probably not going to be something you're going to need to know for the exam. But if we've talked about it or revisited it a lot, it's probably something that's going to be on there. Clicker questions, I did make a document and put it on TigerNet. I'm not sure if anyone saw that. I put under Unit 2, it's a list of all the clicker questions with the answers from this entire unit. So it should be a nice little file for you so you don't have to click through all your PowerPoint. Okay? Use them and look at them. I promise you it'll help you for your exam and what you can prepare for what I'm going to ask. If for some reason you're going through your PowerPoint slides and you don't know what a word is, and I'm just going to say an example for stroke, like aphasia or dysarthria, look it up. Because on the exam, if you see that and you don't know what that means, you may get a question wrong just simply on you didn't know the vocabulary. Okay, so if you don't know it, look it up. What else did I put on there? Like I said, textbooks, I'm not a big textbook reader. I'm not saying that you can't read the textbook, but I wouldn't recommend reading the 400 pages that were assigned before the exam because you're just going to put yourself into a chaos mess. Okay, look up for stuff you don't know. The medication commercials, there were 7 meds. They will all be on the exam, and I do expect those to be more heavy content areas. Just because you know what mannitol is not good enough. You have to know side effects, nursing considerations, and maybe potential lab diagnostics of those meds. Okay, I'm giving you 7 answers to the exam basically by having those questions. Okay, other resources, the review questions. I recommend you go through those on TigerNet. It's a little document that I put on there at the beginning of the semester. And I would suggest doing that after you've studied, not before you've studied, to see what you need to study, like what you feel is the worst content area. It's an evaluation to see where you're at. Okay? Maybe Saturday, once you've studied for a while, you can go through that to see, okay, I know nothing about CDAs. I need to revisit that. The ALS, MS, MG, and GB tables. You guys remember these little guys? I did these for a reason. Okay? It's a nice little precise stuff that's in here. They're perfect little study guides. When you're going through the PowerPoint and studying, you can actually, review. But when it comes down to what does Megan want to know in the exam, it's going to be on these tables. Okay? It's a perfect little study guide for you. Okay? The stroke case study, I am going to put the answers to that. I think it's due at midnight tonight, so they'll be up tonight at midnight. My neuro quiz, absolutely. Those questions will be available to you, I think, tonight at midnight. Look at those answers. And I know a lot of you don't like PrepU or the ATI, but they offer tons of ATI questions or NCLEX questions for neuro. I may not have pulled it from there, but it's extra practice to give you some insight on how I'm going to ask questions. Okay, so there's a lot of resources. For Sunday, 7 o'clock, be there at 7. We're going to start right on the dot. I don't know how long it's going to take. It might be an hour, it might be 2. That's why I suggest that you get your study done before, so I'm not interrupting your study time. Okay, this isn't a time for being, oh man, I'm so sad I went to this review for 2 hours. Well, you should have been done studying anyway. You're not going to be sad, but I'm just saying. I don't want to ruin your study time if you have time to study left. Okay? I know these are no-brainers for a lot of you, but the first exam didn't go well for some of you. These are things that I just recommend because this is how I test or how I give tests. And I hope it helps some of you. Okay? We're going to go through the blueprint. Start with that. If anyone needs to go to the bathroom, this is probably a good time to start this up. Here's those liquor questions I was telling you about. They're right on TigerNet, and so is the review questions. I don't know if this is what you guys did when you're going through your blueprint, but I go down the list, and the stuff that's kind of the little stragglers, like the 1 and 2s, I put what content area they were in, like the peripheral nervous system, CVA, or spinal cord injury, because that tells me exactly how many questions are going to be in each. If you look, I did write a list down of all the questions from each minute. Spinal cord has 18. Peripheral nervous system has 9. And CVA and traumatic brain injury has 24. A big portion of the exam is that final one. But it makes sense, has the most content. All right. I think I'm going to pull this up because everyone has, if someone has their blueprint in front of them, that's ideal, but I think I'm going to pull this up so I can use this board. No, because then it won't record. Okay. I guess I'll have to erase my perfect drawing. Come on, little doggy. Well, since he said it could reach, you have to do this. I don't know why it's not zooming in. Oh, it's zooming in. All right. I don't know if this is going to catch it or not. My writing might not show up. All right. We'll see if this can show on there. If not, I'll do a little camera view on it. All right. So the first thing we're going to talk about on the list is spinal cord injuries. That's our first unit that we went over. The way we're going to do this is we're going to kind of just go down the list of what we think is important. I'm going to tell you this right now. Good enough. All right, so spinal cord injury. Can you remember that long ago, a month ago? First and foremost, no. All right, first and foremost, obviously spinal cord injury is everything about the entire spine, right? A big part of this exam is going to be the location of the spine, okay? So if you're thinking about each one, so your cervical, your thoracic, lumbar. We're going to combine that with your sacral. Okay? What is significant on each one? Think about location and where you're going to actually assess for damage. Okay? If you have cervical injury, higher up, right, the worse off it is. Okay? So you think about C7 and above, you're going to have the highest risk of what kind of complication? Respiratory. Okay? If anyone comes in from the ER with a C7 or higher injury, protect airway 100% of the time, first time. Okay? First thing you're going to assess, respiratory. Okay? What other things would you potentially do to these patients that have C7 or higher injuries? Think about on the field, like the first thing you're going to do on these patients. C-spine, okay? I'm not going to have an exam, what would you do first? Because I think they're equally important. C-spine and airway, okay? For thoracic, what's important about thoracic? Location, what number are we thinking? T6. Everything from T6 and up is considered more significant for respiratory and cardiac because of the location. T6 is nipple line, so think about what's located above the nipple. Heart and lungs, right? Very important. You have T6 injuries, you have higher risk for more malfunction of the body as well. So like your autonomic dysreflexia, that's a key one there. That could potentially be a cause for that problem. Thoracic, think about lumbar punctures in the thoracic area. So those are areas that they could potentially do those interventions. Thoracic is not as intense as cervical, and the reason why is because it's not as easy to have more injury. Cervical, you move a little bit, you could potentially paralyze it forever. Thoracic, not as much. Okay, obviously it's lower down. Lumbar, what's significant about lumbar and sacral? Bowel, bladder, and sex is what I like to think of. Bowel, bladder. Makes sense, right? Where are your lumbar and sacral at? Where your butt's at? Okay, and sex. A lot of people have sexual dysfunction, incontinence, retention, potentially impaction because they can't actually put back. Okay? So think about medications for each one. That's the big thing that's going to come from what I'm going to ask for those little medications that you don't know about. What kind of medication are you going to get for these? Bowel and bladder, they're retaining or potentially spastic, and they're having incontinence. Any sexual, probably not medications there, but education, especially education there. Okay, let's go from cervical again. We're going to talk more about respiratory. What are things we can do for cervical patients on respiratory? Think about nursing diagnoses, things that we might do. Intervention. Assess the lungs, that might be one, right? Assessing. Vital signs, we look at SATs, especially. We could potentially suction as long as we don't have potential intracranial pressure changes. If it goes down to both, if you have intracranial pressure changes that are high, and you have someone that does not have a patent airway, airway wins every time, okay? So just because someone has intracranial pressure of 25, and they're sitting there gurgling because they have so many secretions, still suction them, but you just try to be cautious of the intracranial pressure. You just try not to go for 40 seconds at a time, or give them frequent breaks, or lifting the head of the bed up, doing other things that might potentially help their airway. We can suction. Never on the schedule. It's always PRN as the patient needs. Okay? Let's go to thoracic and what injuries we have for thoracic. Remember the one that we just talked about? Autonomic dysreflexia. What is it? First of all, how does it happen? Overstimulation or stress on the body, usually in spinal cord injury patients. We think about the T6 and higher patients. It doesn't mean it can't happen in someone lower. It's just more frequently seen in T6 and higher. Okay? So the first thing you're going to see in these patients probably is what? Blood pressure changes. Severe hypertension. I'm talking 200s over hundreds. Okay? So let's say you go into your patient's room and you see a person, they just look off, check the vitals. You see this blood pressure, and they have a Foley in. Let's just get a do. What is the first thing you're going to do in that patient? No, you're not. You're going to lift the head of the bed up, right? That's the first thing you're going to do. You're going to go to 90 degrees. I kind of tricked you on that one. Not saying you're not going to check the Foley, because you are. But the first thing you're going to do is put the head of the bed up.
Oh yeah. The feeling that was on that instead. Okay. Explain that to me because I thought that I was.
Think about if you have really high blood pressure, okay? Okay, let's say you have hypotension. Someone is really low. What do we usually do with those patients? We lie them flat.
Then you put it down with it.
Right.
Okay, I had a big.
Yeah, thinking about your blood pressure, the blood will come down from your head, and that could potentially not have a control. So hypertension, when your blood pressure is through the roof, put the head of the bed up. It helps the blood come back down. Okay? And then if you were hypotensive, lay them flat. Or Trendelenburg, remember when the head of the bed is down? That is so the blood can go back to the head. You don't have enough blood pressure to get back. Okay?
Don't they have low blood pressure like below the?
For autonomic dysreflexia, nope, they have hyper. High. You will see very high blood pressure. And the reason why is because the stress in the body from potentially like a kink in the Foley impaction will cause those nerves, like sympathetic nerves, to basically be stimulated. And that's why your blood pressure goes through the roof.
Isn't there one where they have low blood pressure like on the
That's I think neurodynamic shock, essentially. You will see bradycardia with this. Hypertension and bradycardia. Okay, so first thing we do, 90 degrees. What's the next thing we do? Right, so you probably checked your vital signs at this time. That's why you're turning the head of the bed up. You wouldn't just do it because you thought it was going on. Your vital signs, you probably just went in on assessment and you found this on an assessment. Okay, so 90 degrees. Before you call a doctor, because you will call a physician, you probably should check for kink Foley first, because he's going to go, why didn't you check? That's going to be the first thing they check. So if they have a Foley, check for kinks. Because the kinks can cause retention, and that can cause a pressure inside your bladder that's pushing on those nerves. Okay, that is why they have that potential retention. So we have 90 degrees, Foley. Next thing is call the doctor. Okay, MD. Okay, what's the doctor going to order? Let's say the person doesn't have a Foley. Then you probably put a Foley in because they were retaining some spinal cord injuries. They can't actually get the P out. Okay, so they have retention. You have to put a Foley in to relieve that pressure. Let's say they haven't pooped in 6 days. They might have you give a laxative, an enema. If it's still not coming out, they may have you disinfect them. Never had to do that. They would never do. So that could happen. Okay. So what they do is the doctor will look at the whole picture, maybe put a Foley in. If he does have or she have blood pressure in the 200s, they're going to order antihypertensives. Okay? Expect those for meds. What's an example of an antihypertensive? You can do that, but they do have bradycardia in these people. So you would not want beta blockers. If you do a calcium channel blocker, they do have effect on heart rate as well. I'm thinking a nitro. Yep, nitro is only affecting blood pressure. They do have bradycardia. Okay? But nitro is your first line of choice. You'll see a lot of patients in the ICU on nitro just for blood pressure. Drip. You'll be on a drip. Okay? Goal for these though, we do not want that blood pressure to go down too fast. We never want to go from 200 over 100 to 120 over 80 in 4 hours or less. We want a nice slow down. Okay? All right. What else on thoracic? What else I have? All right, let's talk about secondary injuries from spinal cord injury. Secondary. The primary injury is spinal cord injury, right? That's the actual injury that's occurring. What is the secondary injury? Something that's caused because of the primary injury. Okay? What's one that you can think of if you were in a car accident and you're rolling down the interstate and you get punctured by a glass into your spine? You go right through your spinal cord. That's like a penetration injury, so you could have hemorrhage, right? Okay? What kind of things are you going to see with hemorrhage? Okay, we can have shock. There are lots of different shock in this unit. Do not mix them up on the exam. Okay, we have shock. With any type of shock, the way I like to remember, I remember neurogenic shock. All the other shocks are the same. Okay, if you know neurogenic, which is bradycardia and hypotension, everything else is the same for the other shocks. Okay, that's the only one that's different. But spinal is not an actual, if you think about shock as a definition inside like the nursing definition, shock is a state of the entire body going through a process of shock. Spinal shock just means when you're going through an accident or an injury, your body goes through like a shock from the accident. It's not a state of shock. That's why it's confusing. We'll go through that in just a minute too. But this shock, you'll see heart rate and blood pressure low. Why is your blood pressure low? Your tank's empty, you're bleeding. Heart rate's high because you're going through a stress, okay? Dehydrated, hypovolemic shock, and hemorrhagic shock are very similar, okay? One you need fluids, the other needs blood. That's the treatment difference. If you are hemorrhagic shock, and you give 6 liters of fluid, it's not going to fix the underlying cause. You need blood, okay? So that would be your first sign of choice. They might start with a liter of saline, but if it's not working, go to blood, okay? You can go to the other shock, neurogenic. What is significant about neurogenic? First of all, what vitals? Hypotension, bradycardia. Okay? With neurogenic, that's the only one that has low heart rate, bradycardia. All the shocks. Okay? With neurogenic, it usually happens within the first 24 hours. Okay? But it usually does not happen for at least 6. So 6 to 24 is the happy medium for neurogenic shock. With spinal shock, even though it's not a state of shock, it's just how it's termed. This is on initiation of your injury. You have a car accident, you have a spinal shock, you have a shock on the body. Remember how we said we do not tell patients or their families the prognosis until at least a day or 2, right? Because it could be a state of spinal shock or it could be reversible. What do you see in spinal shock? You do see hypotension and you see bradycardia. It's similar to neurogenic shock. Paralysis. That's why when people go to the hospital and the family goes, they told us we'd never walk again. Well, we're walking. Because they had a state of spinal shock. Okay? Some doctors might say, oh, this is a C9 or a C9. T1 injury, this is pretty significant. You may not walk again. Okay? But we found out that they're in a state of spinal shock. They reversed in 3-4 days, and now they can have sensation and walk again. That is what people go through. Okay? Let's see, what other shot? We talked about hypovolemia. Then say these are. So spinal shock, you tell them what it is. Yeah. We don't really know it's spinal shock until after the state that it's already happened. But they could be potentially paralyzed forever. We don't know. That's why we always give it a day or 2. We stabilize them for what injury they have. They have a C6. Stabilize them, maybe intubate them, wait. Doctors shouldn't say anything. We just say, we know that we have a C6 injury. If it's a C2 or C1, it's really significant. We say this says, shown in the past to have these types of problems or what we expect. We can't really anticipate anything until a couple days. But these people are probably very unstable. That really injuries. Immediately, yep. This one will be at the time of injury. It could be, but that's where it gets kind of screwy because neurogenic shock and spinal shock have a lot of the same symptoms. Okay? So initially, if we suspect that there's something going on, we suspect spinal shock, but later is when we suspect neurogenic. So we expect up to 6 to 24. Because usually it doesn't happen for that first few hours. They have to have a pretty significant injury to be in neurogenic shock after 6 hours. Okay? But it happens. All right, secondary injuries. What else? Ischemia, that's one. Which ischemia is pretty basic. Not getting blood flow to that area, potentially from swelling. And so you can have loss of function below the level of injury. Think about always below. If you have a T9 fracture, everything below T9. Okay? Ischemia is pretty loss of flexibility and motor sensor. Okay? That's the autonomic district. Okay, let's say for your patient, they have a C4 injury, what are you going to suspect is C4? Let's say it's a bad one. Respiratory, so you're going to expect them on the bed, right? They might be, if it's a significant injury, be on the bed for the rest of their lives. Okay, if it's significant enough. Think of C3 through C5, keep the diaphragm alive. Okay, you always hear that saying. C1 and C2, I'd be surprised if you live through C1, C2. I have known someone with a C2 fracture that was minor, kind of nicked the back of the lamina, but they still sent them on to falls. They lived through it, they don't have paralysis, they were not even on a ventilator, okay? Depends on the severity. And when I talk about injury, I talk about spinal cord injury, not necessarily the bone gets fractured. Sometimes they don't have any problem at all. Okay, so C4 injury. All right. What types of interventions are you going to think for a patient that might potentially be in the hospital for a few months for this core injury? Think of things that we might do for these people. Say that again? Okay, therapy. Potentially we might need to get them active because they're going to be in bed for a long time, right? They have a history or a potential for DVTs, ulcers, skin ulcers, pneumonia. What type of devices are they going to have on, maybe? Halos, remember? We talked about halos. What's the best? What's that? That's only for the transducer, that's only for intracranial pressure reading. That's not the same. But with the halo and vest, remember what we have, the halo around the head? If they're inside the bed, we want to make sure that they are staying in neutral spine. We want to log roll them. You never want to twist their body or have them reach for the trapeze. Always keep them in neutral spine. Halo vest will also help that. It's going to keep you nice and neutral. You can see this up to 3 to 4 months. What are things that we're going to consider with halos? Pin care, there's holes going into your cranium, you guys. What can leak? Cerebrospinal fluid, so infection, that's definitely one. Leakage or drainage, potentially it could be, bleeding through there. What about skin care? We want to make sure the skin under there is not getting pressed up on the metal bar, because that can cause breakdown. So we'll inspect that at least every shift. That's going to be at least every shift. Okay. What about, talk about position. If they have intracranial pressure increases, that's more with a traumatic brain injury, it affects their brain. But sometimes they can have C4, which is with the spinal cord, and have nothing to do with their brain. The only reason the halo is touching the brain is because it needs a place to connect for a neutral spine. Okay? You may have nothing wrong with your brain at all. It's just the pins have to go somewhere. Okay? Sounds pretty good. Skin. What's that?
Do you monitor their hand?
For circulation? Yeah, and that's things you'll do too because they're in bed all day. You want to make sure you do your 5 Ps. Remember our assessment of 5 Ps? That's with every neuro patient. And honestly, you should be doing that with every patient all the time. 5 Ps should be always something you look for. Looking for paralysis, circulation, are they pale or white? Pulses, always making sure pulses are there. Any numbness, tingling, those are also things you always look for. Okay, what do we do for DVTs? Give me 2 meds. Lovenox. Heparin, Lovenox. What about longer term? Coumadin, if they can swallow, they'd have to be able to swallow for that. They would give Lovenox and heparin for IV or sub-Q, depending on what they were getting. Okay, skin ulcers, what are we going to do? Repo, special mattresses, making sure that they are, the air mattresses that rotate. I know this sounds easy, but there are a lot of questions on the exam for nursing intervention. Okay, things that you would do for these patients, it may not even pertain to the injury. What you're going to do for longer term, because they're in the hospital for a long time. Okay, pneumonia. If they're on the ventilator, we can't really tell them to turn, cough, and deep breathe. Incentives spirometer, but on the ventilator, we would make sure we're suctioning appropriately, only when they needed to, but also making sure appropriate antibiotics were on board early, so they're not having severe sepsis or reactions to the bacteria that might be in their lungs. You can get something called ventilator-associated pneumonia. It's very common in vet patients for longer than a week. Just thinking about all that stuff that's in your mouth, it is very hard to keep infection out of your lungs. Okay? I don't know if they can actually do that. All right.
Are those patients going to be on like nutrition supplements if there's nose or
Yep. So potentially, when they first are intubated, they might be on an NG tube, so for nutrition, or they could potentially be on CVN through their veins. But if they're going to be on a vent for the rest of their lives, yeah, they're going to have a G tube. I thought you were telling me not to raise it. Right. G tubes will be placed, and they'll kind of go to the nursing home potentially for a while or a rehab facility. If you suspected a head fracture, but that's why they do head CT. So the head CT, once it was ruled out, then you could put an NG down. But if you suspected a basilar fracture, remember the raccoon eyes and the battle sign, you would never put an NG tube down. You could go into their brain. I think someone was telling me in clinical.
yeah, Lisa. Oh my gosh.
Yeah, tell that story. That's
For that, when we put it in our brain or
they put the NG tube in, and then they actually put feeding tube supply in, and it went into their brain. So I mean, you have to be careful about going inside. A lot of people will do oral gastric tubes, but it's easier because it gets rid of your deflated stomach. So OGs might be a better option for any type of head injury. Yes, you can always, if you're inducing something in there, you can check placement with air, and you push that air down the NG tube and listen with your stethoscope. You'll hear like a whoo, like that noise, and that means you're in the right place. If you don't hear that, do not put anything down. If you're putting NG down for the first time, you would never put anything, not even testing for air, until you get a chest x-ray. So you don't want to push air in there. Yeah, if you suspected that it's not the right place. Most of that time, the bile will come up, and you're like, there's no bile in the brain, so I know that I'm in the right place. You can test pH of the bile stream. Is there any other questions about that? No? All right, let's keep going because we want to get through this. Multiple sclerosis. What do we know about multiple sclerosis? Women are way more affected than men. It's unknown how much, but they've seen it up to twice or 3 times as much. Okay? There's no real rhyme or reason why. They don't even really know why people get MS. They've kind of linked it to genetics. There's still some studies out there that say no genetics. But genetics, it's an autoimmune, meaning that your body literally attacks itself. Has a lot to do with the neurons in the myelin sheath of your neurons. And it's a degenerative process that gets worse over time. You can have exacerbations or improvements. What are things that make exacerbation worse? Temperature. Okay, so extreme heat or cold. Maybe a lot of activity. They do encourage that they walk and exercise, but not to the point of exhaustion, because then you're going to trigger an exacerbation. Okay, so exercise is good in small amounts, and getting their tolerance up. You would start them on a 2-mile walking regimen their first day. Okay, you might start with a half or a fourth. Okay, what else with MS? What are some meds that we can give? What's the commercial med? Backbone. Just going to guess this is on the exam, this is on the commercial. What do you think I'm going to ask on this question? Okay, parasite. Okay, injection site. What about it? Obviously, it's going to be given sub-Q, right? Right? There's injection site. Sub-Q. How often? I had daily for mine. Some people take it daily. That's what I have for my record. And for my PowerPoint, I have it daily. Remember, I'm just going to say for the sake of this, remember daily. Okay? Daily. Unless you can find some literature otherwise, but daily. What other things would you look for? These people have to educate themselves, or we have to teach them how to get these injections. They want it. It just depends on the patient. Some people get that adenoma, that like bad tissue, scar tissue. A lot of people can't give it to themselves or else from the belly because it's hard for them to move. And that flaccid to their or their lower extremities, so it's hard for them to maybe get in their bottom or potentially give in their arm. They're not coordinated enough. The belly is usually where we encourage them. A lot of people can't stick themselves. It's a lot harder than you think. We're nurses. It's not that big a deal. A lot of people are scared to actually poke people. So they might have to have a home health nurse come in once a day. And I actually, I worked for a lady with MS, and I had to do that. So I went and help her do that every morning. So it's not, I don't really remember what the med was, but I would imagine it was something. Okay, what other, the other side of this? They can have some, I know, irregular heartbeats, and I know cardiac can be affected as well, but injection site is key. This is probably their number one. It gets better with time. We don't just say, oh, they can't tolerate it, you should probably take this one. No. No. We're going to continue doing it. We might just alternate the area of injection. Okay? Let's see. How do we diagnose MS? A lot of these neuro problems are going to be based on symptoms. You are right, Sarah. They can do MRIs of the brain that show what? You see white plaques, what you'll see. Okay? I don't know why, but I feel like, I don't know if it's this area of the world, but I feel like I've known a lot of people with MS. And maybe it's everywhere like this. But I feel like a lot of people, the first thing they did is they started seeing degenerative things over time where they got weaker and their cognitive ability started to be affected. So they went to get an MRI and they did find these little white plaques over their brain. It's not conclusive. They can't say, yes, you have MS, you have these white plaques. It's all symptom-based. What you would see is exacerbations and getting better. One day you might feel great, the next day you feel like crap. Okay? And that's what the doctor usually does. He can suspect it from the MRI, and he might start something like copaxone, but you have to look for improvement in your daily day activity. You are never going to have a cure, though. So over time, it will get worse. No cure. What's the lifespan on these people? I shouldn't say people, like but this population. They can live long lives, may not be the most quality lives. Okay? After time, maybe the last 10 years of your diagnosis, sometimes more, you might see more fatigue, more weakness, potentially paralysis. You can see a lot of problems with bowels. Constipation is a very big problem. So they might be on daily always to nurse. Okay, I think we get most of the MS. Cognitive, since it is a spinal cord, or it's dealing with your spinal cord, it wants to do with that, and your neurons in time, in your central nervous system, there is a lot of cognitive problems. Okay, so that your brain will be affected. ALS. We did not get a chance to lecture over this. There was 3 slides, I believe. How many questions on the blueprint? 2? 1? 2? This or 1? With ALS, I want you guys to know that this is probably the worst of the 4 that we talked about. Okay? Heard of Lou Gehrig's disease? What this is. Heard of the ALS challenge that everyone did last summer. They put water over their head. What they did it for. Okay? ALS has usually a lifespan, once you find out, of 3 to 5 years. Not very long. What is usually the reason they die? Okay? How does this disease progress? From top to bottom. Top to bottom. What is that called? Descending. Makes sense, right? It descends from the top. So it makes sense that it would affect them faster if you someone from ascending. Because if you start here, how fast are you going to get to respiratory? Pretty fast. If you start at the bottom, how long is it going to take? A little slower. Okay, for about healing rate. Okay, so respiratory is definitely a problem. Would we intubate these people? Controversial. They probably have a different. Okay, most of the time they have to get their advance directives sometime in line when they get diagnosed. Most doctors will answer your question just. Most doctors will have us talk with them right away if they have diagnosed ALS. They'll say, here's the prognosis. They have to be realistic. Okay, we might be able to bypass them, just to kind of get them by, so they might be having exacerbation, but it gets worse, 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 worse. They don't get worse, better, worse, better, worse, better. It just goes down, okay? So we usually tell them if they're already on ventilator support, you're probably end stage, okay? You know it's not a happy thing, very sad situation. Get ALS, very emotional, psychosocial, okay? So we have to be considerate of their feelings, because this is definitely, I hate to say it, but it is a death sentence, usually 3 to 5 years, okay? Medications, I'm not going to worry about as much for this, because I'm more worried about the process and what you're going to do if you have a patient with ALS. Okay? Pretty much all. Okay, it's
Spending, but they're not like strong.
right. They do have some weakness anyway. If their whole body's affected, it still is your neurons being affected. It's actually very similar to MS and how it's affected with your myelin sheath. But this just has a quicker rate of progression. Right. You still have cognitive issues because it's a central nervous system. So you will have cognition problems. Okay. Oh, here. That's why all this research money is going out. And I'm not sure how ALS got started with the, all the money going towards this one. There's a lot of problems out there like MS, myasthenia gravis that have a lot of attention too. But this one took like an all-time high last summer. So I'm curious to see if all this money they raised is actually providing any research for a potential cure. This one, I think women are actually covered more. I'm not entirely sure. I just don't want MS. Okay, we're done with spinal cord injuries. Let's go on to peripheral nervous system. Peripheral nervous system will be quick because, any questions? All right, what's our first problem? Guillain-Barré. Okay, peripheral nervous system. Since it is affecting peripheral first, or only, you do not have much cognitive changes in Guillain-Barré and myasthenia gravis. Okay, they usually have their mind intact. It's everything else that's not as well. So what's significant about Guillain-Barré? Yep, you can have ascending or descending, but ascending is more common, where it goes from the bottom up. Okay, if you have descending, it's a way more severe case, but it's very rare. Okay, so you can have paralysis or weakness, depending on the severity. Not all people have the same symptoms. Okay, some people might be affected only in the feet. Some people might be all the way up to their belly button. Not 1, 2 people are the same. Okay, where is the problem at? How do they diagnose this? Okay, they can do an MRI or CT scan, just how we did anything else, but what are they looking for? That's what probably caused it, like a viral infection or autoimmune. They can see that too. They can ask them, have you had a viral or intestinal respiratory infection? Okay. Yep, that's what I want. Those are Ranvier. Those are Ranvier. Okay, when they do their scan of the axon, they're going to look for these nodes of Ranvier deconstructed or broken down. Okay, if they see that, they can suspect this one for potentially like MS or some other problem, that this could be the actual problem. Okay, but it always comes down to your symptoms. Remember, symptom based. These are just things in conclusion. We talked about causes. What are our 3 stages of this disease? Okay, so you have your acute phase. How long does that usually last, and what does that mean? 1 to 4 weeks. And what does that mean? Acute means that is the potential for your severity of your symptoms. After 1 week, it might be, okay, this is the worst you're going to get. Okay? It might mean after 4 weeks, you're still getting worse. You're not at your peak yet. Okay? Usually, the faster you get worse really fast, they can assume that this is a severe Guillain-Barré. But if it's a slow process where you just have weakness in your ankle for a week or 2, it's probably not going to get very bad. So 1 to 4 weeks, then you have a plateau stage where the symptoms stay the same, but they don't get worse. Okay, so that's the time where we can reintroduce maybe activity, getting them strong again, potentially working with physical therapy. And the recovery can take a very long time because what does it need to do? Could be up to 6 months or a year even. Your degenerative nerves need to basically grow back. Okay, so it depends on the person. Not everybody will get 100% back to the normal state, but most will. Okay, get Guillain-Barré and get rid of it. Okay, it's not something you get forever. They say with immunizations, that's why they ask if you ever had Hullinger, because it can show that your autoimmune system is not as intact and that you have a potential to get it again. But they do say that Hullinger, if you get it once, you have the same chance of getting it again than anyone else in the public. Okay, so it is based on maybe previous viral potential autoimmune disorders. Okay,
And know all the things that like I know it's like
you mean like for viral illnesses?
yeah.
No, I would probably just stick with the autoimmune and things like viral have been the most common. You guys know those less enough. Okay. What are some potential treatments for Hullinger? Plasmapheresis or IVIG pheresis. I am going to tell you this. For the exam, I'm not going to have you know the actual procedures of those. Okay, just know that those are potential treatments for those. Okay. I know I talked a little bit about shunt care and how to do that with plasmapheresis and how it's kind of like dialysis. They take all the antibodies out of your plasma, and that doesn't help you, so it doesn't. So kind of know generally what it does, but you don't have to know specifics on how to care for plasmapheresis. Okay. IVG works kind of the same way. What is one thing we do not give? Steroids. Right? No steroids. It can potentially make it worse. Okay, so that's the only population you don't give steroids in. Every other disorder, I swear you can give steroids to, you'll be fine. This is the only one you do not give it in. Okay, let's go to myasthenia gravis. Keep moving along here. There's a lot of questions on this one, isn't there? Who's on board? For questions? 3? Okay. Myasthenia gravis. What is it? Someone going to tell me the path of this?
Blocking of
What's the important thing that we talked about? Acetylcholine, right? That's the whole reason why myasthenia gravis works. Okay? Or the reason why it doesn't work, I should say. Acetylcholine, I'm just going to abbreviate it like this. Okay? What does acetylcholine do? It's a neurotransmitter in the muscles that helps the muscles move, right? If there's no acetylcholine, there's no muscle movement. So we do need acetylcholine to actually move, okay? So in this problem, you have something called acetylcholine esterase. Remember, esterase in bio means to break down. If it's breaking down all the acetylcholine, your body can't use anything, okay? So there's no acetylcholine to use. That's a bad thing. You have too much of acetylcholine esterase. Okay, so if someone has myasthenia gravis, we're going to do a test. What's that test called? Test one. Okay, very important test. You have to know exactly how this works. What do they do? They inject. It's Tensilon. What is Tensilon? It's acetylcholine, you guys. It's a generic form of your body's acetylcholine. So it makes sense if you give Tensilon. What happens? You start to work. Your muscles move, they show improvement, okay? Increased muscle movement. So let's say we're suspecting maybe from a CT scan or MRI that they might have myasthenia gravis, or they're showing decline over time, they're getting more weak. We do a Tensilon test because they suspect it, and let's say they improve and they're able to walk for 60 seconds to a minute. And it's way better, they don't have that weakness. We can potentially think that it is myasthenia gravis. That's one way to diagnose this problem. What's another way they can do it? A lab. Say it again. Okay, that's a test they can do in the muscles to test if they're weak. That's usually for all the problems, the EMG. They go test the muscle contraction and see how it's talking. But I'm thinking of those antibodies. Remember those acetylcholine esterase antibodies? Do you remember those a little bit? So these antibodies break down. I'm not sure it's like if they see this lab positive inside the body, they can assume that those antibodies are killing the acetylcholine in the body. Okay? They're breaking down the acetylcholine. Antibodies are usually a good thing, right? Not when they're on the defense team for acetylcholine esterase. Okay, they're breaking down acetylcholine. They're helping the enemy. Think about that. Okay, so this is one diagnosis you can look to suspect, or potentially a tensilon test. Yep. Okay, so think about tensilon testing. Now we're going to go into the two crises that you can see with myasthenia gravis. First one, myasthenic, right? Cholinergic, right? What does it mean? What's the first thing? So this is obviously after we've already diagnosed myasthenia gravis. They could potentially go into these two crises. If they're experiencing a myasthenia crisis, it means they're not getting enough meds. They could get forgetful, forget to take their meds, not take the appropriate amount. Or their body physically needs more and they're not taking the appropriate dosage. So too little of their current medication. Not as important as what meds they're getting. I'm going to stress that for the exam. I'm not as concerned about what medications they're getting for myasthenia gravis. You know neostigmine, that's one of the common ones. I wouldn't get too caught up on all the other ones that are given for myasthenia gravis, because that's your commercial med. Okay? So too little to med. Cholinergic is more or an extensive amount of med. Okay? And too much. So what can we give in myasthenia crisis? We can give more of the medication, right? The neostigmine if we need to. Sometimes it gets to the point where it's so bad in a crisis, what symptoms are they going to have of the crisis? In the myasthenia crisis? Respiratory is going to affect both, which is nice because you know on an exam if I ask you when you at least know respiratory is one of them. Okay? What vital signs for myasthenia crisis? Hypotension, okay? Low blood pressure. For cholinergic crisis, they're going to have everything increased. Oh yeah, you're right. Sorry, confused. Hypotension for cholinergic. Everything else is increased for myasthenia crisis. So heart rate, respirators, and blood pressure. Okay? So if you have a patient that is a myasthenia gravis patient, they come in and they're having all these symptoms, and I mean severe, like heart rate in the 140s, respirators potentially in the 40s, blood pressure in the 180s over 100. Okay? Have that, and you have a maybe suspicion that they haven't been taking their meds, you can assume they're in a crisis. These people might be on ventilators, and how they can actually get their meds restarted. Most of the time for both of these crises, they're actually going to have to cool off on the crisis period before any medication is induced or given. What medication would we give for a cholinergic crisis? Atropine. How much? 1 milligram. Okay, so atropine is actually given in a tensilon test to reverse the tensilon given. Remember, tensilon is a fancy thing for acetylcholine, like the medication for that. What's that? What if you had VTAC for 5 minutes? Is that a long time? Okay, so you give atropine to someone that had VTAC or VFib from a tensilon test. They can give alternative forms of tensilon that is not as severe. I'm having a brain fart for what that medication is called. Do you want to know? It's the alternative to tensilon they can give so they don't have cardiac effects. I don't have it on here, so it's not important, but but you can give a certain type of medication for people that have histories of dysrhythmias, because this has a very potency on the heart. Okay, so atropine will reverse the cholinergic crisis of too much of the acetylcholine. Okay, so that's something you give. So let's say on a test, I ask you a question, and you maybe suspect myasthenia crisis. You're not going to give atropine, right? Okay, don't put that in. I'm not going to actually put you're having a myasthenia crisis, but there might be symptoms that clue you in. Okay? All right, I think that's pretty much all of myasthenia gravis and really parade. We only have about 10 minutes left. We'll start CPAs. Are you finding that you think you need a lot of studying left to do?
Yep.
All right. Yeah, if you feel like you're answering these questions properly and you feel like there's a piece in more than you think.
Go for the ISD coverage crisis. So when they come in on the crisis, okay, so if they come in on the corner crisis, they're gonna give them aspirin. If they come in on the ISD crisis, you're gonna let them like cool off.
Yes. They potentially be on a ventilator, so you would induce their medication slowly. You would never want to give them too quick. Yes. Yep. All right, CVAs. What do we know about CVAs? This is probably pretty few, but
But I have a question. So if they're like coming in like grading their part, so they on the ventilator,
well, it depends if their stats are low or how they're
they have
reacting.
to like sedate them?
But if they're truly in a crisis, they should probably be on a ventilator if their respiratory is that bad.
Are they gonna be like fighting?
Restless? Not always. If anything, they might be more lethargic. So yeah, just a minute. What's your other question? All right, CVAs. Let's talk about the first one. Left side versus right side. You have to know the difference of what you're going to see, what symptoms, everything. You have to know what you're going to see on assessment. Because when you're a nurse and you come see your patient that's having problems and you notice a level of conscious change, it'll be very helpful for you to know what type of brain is affected and what the symptoms are. What about left side? What are you going to see? What's wrong with
Run
right? Right side is affected. What else? For the left brain stroke. Think about, remember, a left side thinker versus a right side thinker. So speech would be for left. Think about speech and language. Maybe like math process. You ask them to do 2 + 2, they might not know the answer, but they don't have the thought process down. What about vision? What kind of things will you see? Remember that long word? Movement. Let's see if I can do it. The analysis. What does that mean? Is it both eyes or just one?
both sides.
Both eyes, okay? What this means is the right side is affected. You can't see on that right side. Get the left side, okay? It's the opposite of what the problem is. What other things did you see the left side in? How do they learn best? Demonstration. You're going to talk to them. Verbal, say you were in there just talking to them. They're going to be looking at you because they can't, the cognitive is not there. That's impairment. Okay? They may have trouble focusing on words and getting their words out and their thought process. Really effective. Okay? So demonstration is better for them. Let's go to right side. It's obviously going to be the opposite for the weak. Words might look at Deja. Okay, left side weakness, paralysis. What other things are right side brainers? They're the creative people, right? Right, impaired judgment, that's going to be a very big one. Potentially spatial problems. Remember the proprioception, where they can't feel their arm in time? If you were to have a right brain stroke, they'd lift their left arm up, or you would, they wouldn't be able to tell that you're even moving it. Okay? They have total neglect on that side. Proprioception. Okay, what else here? Did the impulsive activity, how do they learn best? How do they learn? How do they verbal? Remember their speech and their thought process is not as it is affected with getting their words out and actually comprehending words. So verbal would be better for both. Right side of the one. No, you're right. I think you might be right. The right side is the one where they don't think they have a problem, or they don't think anything's wrong. They might be more negative. Right. What type of strokes do we have? We'll start with hemorrhagic. What is it? Bleeding. Okay. So what's going to be different from ischemic? Which one can you give thrombolytics to? Ischemic. You would never, ever give thrombolytics to hemorrhagic stroke. We'll make them worse and they will die. Okay? What do we need to do for a scan to tell us if we can give that med? Scan. So make sure the CT scan is done, which I will say, hospitals are awesome at this. They come in with a potential stroke. CT scan, I think it's a protocol. 5 minutes or less, you have to have the scan done. Very, very fast. We literally take them in and put them right to CT scan, okay? Time is money, right? What's the time frame that you can give a thrombolytic for a ischemic stroke? Goal is at less than 3 hours. I've shown some research out there that 6 is becoming the number, but it's not confirmed in textbook for your NCLEX. I would say. What are some thrombolytics? TCA is going to be your number one. So what I want you to know for the exam. I don't think I've ever seen anyone get anything but TPA. And I think the reason why someone might not get TPA is if they've had like a reaction or allergic problem to it. Okay? TPA is going to be your number one. So what are things we're going to do if we give TPA? How do you give it? Pill, IV push. Definitely do the IV. It's not a push. They put it in this little bag and it takes about 10 minutes. Very fast. But it goes in a little bag, like a little piggy bag. Your person, it's 10 minutes. Okay. Yep. What are we going to look for in TPA? They should have a resolution of their symptoms if we get the actual clot, or at least an improvement. Okay? If we can do it in that less than 3 hour time frame, they have a significant amount of improvement or potential to rehab may be cut down significantly as well. Okay? So TPA can have a wonderful effect. Let's think about bad things with TPA. What could it cause? Bleeding. Okay? So we have to be very cautious. Let's say they already take Coumadin or aspirin and they still have a stroke. They may have a potential risk to be bleeding. Let's say they come in and we draw a set of labs before we give TPA and their INR was 7. Are we going to give TPA? Sorry, you're probably not a candidate for TPA. It is very difficult to find the perfect candidate for TPA. Okay? That's why it's usually not given. One, a lot of people have symptoms off and on. They don't come in soon enough. They might have said, oh yeah, I've been feeling like this for a day. Oh, sorry, you're out of the time frame. But if it happens in the hospital, sometimes it does. They have surgery. Think about post-op, you have a DVT. We notice a neurological change right away. Take them to a CT scan, we notice the change, we can give TPA right away. They have the best prognosis. There's an improvement. A brief one, I'm going to tell you that. TPA is important to give as soon as you can. Most nurses, once you work long enough, you know the gist of the NIH stroke scale. You can test the motor, sensory, seeing if they're talking to you. A lot of the tests can be done. Yes, it's done your basic primary assessment. All right, anything else on hemorrhagic? What can it do to ICP monitoring? Okay, your ICP can go through the roof. What's a normal ICP? 15 is a good rule. Some people say 20, but I think less than 15 is better. Okay, what else for strokes? What's the high risk? Someone that might be a high risk for stroke. Okay, hypertension, AFib, cholesterol, obesity. What type of people? Men or women? Men, elderly. Right, so different ethnicities. White is not as affected as the other ones. Okay? Assessment. What are we going to do for an assessment of the stroke? NIH stroke scale. You're not going to have to memorize this, but just know that it tests the cranial nerves. It's looking at motor and sensory in your development of a stroke. You will do an admit, so like Brianna was saying, when they come in, at 24 hours, we will keep everybody, you should, unless they refuse care, with a TIA or a suspected stroke or an actual stroke. We will keep them for at least 24 hours and do the assessment again at 24 hours. If it's negative at 24 hours and they're not showing any decline, they are able to go home. Okay? Let's say it gets worse or it stays the same as the score that they keep in, they might potentially stay longer in the hospital. Okay? What else? What's the GCS? What's good? What's 15? What's horrible? 3. Okay, so you get 3 just for being alive. I'm going to have a test question. I didn't decide this on GCS, but I'm going to provide the scale. Okay, so it's not you have to memorize the scale, but I do expect you to use this. because I want you to get to the point where I know you know 15 is good and 3 is bad, but I want you to get a good idea of what a number would look like from a picture of a person that you're going to get. Okay?
Are you choose what?
You'll have to, and I'll make the actual question obvious of what you'll actually have.
So you're not gonna put like 6, 7, 8, 9.
Oh, I'm going to do that.
Oh, great.
But it's going to be obvious what the person's going through and their symptoms. You should be able to correlate it to it. So that's exactly what it's saying. Okay? But yes, I did decide to put a question on there because I think GCS is probably one of your most common assessments you're going to do. Not in the ICU, not in the ER, but even on the med surg floor when you have a change in status. You should be thinking to yourself, this GCS score is less than 8. We should be thinking about intubating this person.
So NIH one.
Right. Yep. Right. Okay. Motor and sensory, we'll also look at that for their weakness, making sure we're testing that. Let's see, what else for assessment? Let's do care of a CVA patient quick. What are some things we're going to look for? What problems they're going to have? I'm thinking like a week out of their diagnosis, not the first 24 hours. Swallowing. Let's do that one first. What is important with dysphagia? What's the first thing you're going to do?
Respiratory.
They do have a risk for aspiration, but we're going to consult somebody. Who we consult there? Speech. They are going to do a thorough eval of your patient. You will never have to do the first evaluation. You shouldn't. That's out of your scope. Okay? That is why speech therapy comes in. They test the dysphagia, they test the swallowing, they evaluate SAS the entire time, and they tell us what the risk of aspiration is. Okay? Let's say that they come and they order a diet. It's thick and liquids, parade meats, whatever that may be. You're going to feed the person for the first time. Should you delegate that to a CNA? No. The nurse should actually be present. The CNA can do it, but a nurse should be present to evaluate aspiration risk and potentially problems, okay? CNA can do it after the first couple times so we know what the problem is or if they're doing well, okay? Just not the first time. Okay, so what are they going to do with a person that has a stroke and swallowing? Okay, never put it on the affected side. We want unaffected side always, and that pertains to everything. That pertains to getting them out of bed, to putting stuff within their reach, to feeding them. Never put it on their neglected side. And their vision might be affected as well. So never approach them on the affected side. What about position of bed? Don't they low? We're going to feed them on their back. No, 90 degrees is what we want. Okay? Especially those first times. If they're showing signs of improvement or they're doing better, they may not have to do exactly 90 degrees, but that first 5, 6 times until they get their actual swallowing down or they're getting improved. 90 is what we need to be at. I'm not kidding you. Completely straight back. Any type of variation, they can choke and then they can have a problem. Okay? Let's say you're feeding them for the first time and they start desatting or they cough a lot. Do not keep feeding them. It happens with CNAs all the time. They'll say, oh, it's okay, just cough that up and we'll go out to your next bite. No, they're choking. They can't tolerate the food. Stop. Okay? What's another thing you can do for these patients? Tuck the chin. What does that do? Opens up that, yep, closes your trachea and opens the esophagus. So we just tell them to tuck the chin. Same thing for an NG tube. Think about how we put NG tubes in. We have them tuck their chin once it's past their oral pharynx. Then it goes down their esophagus and not their trachea.
You tell them about like spiritual.
We actually educate them severely before they start eating. And we'll say, we've never done this before. These are things you can do to help the process of swallowing. Sometimes they're not cognitively there enough to tell them, so we have to do it for them. We have to pull their head down a little bit. But small bites, very, very small to start. Never start with thin liquid. Okay? Always start with thick. You always want to start with the most thick, work your way up to the least thick. Okay? All right, what other problems with strokes they might have? Might be in the hospital for a long time. What other problems might have? Activity-wise, they might get ulcers, making sure we're repositioning them. They have to be able to tolerate physical therapy, OT, and speech therapy for 4 hours before they can go to a rehab facility. Okay? So they might have to go to the nursing home until they're strong enough to go. Okay? When I say stroke facility, I mean actual ones that focus specifically on strokes, not just a nursing home that offers PTOT. That's not good enough. Okay? I'll actually do actual good there. It's 10:50. I'm willing to stay around for anyone that wants to stay around for the last part of the traumatic brain injury, but if you have to leave our class, Yeah. Yeah, there's one little spot with a traumatic brain injury and then we'll be done.
They painted everything. They're like your doctor. I'm sorry. And then they're like, and they told us that we had to go and that's the other thing. No, we're not paying for this one. But they came in before we even told we could pay it. They came in, I'm just wondering, like, last week, beginning of this on Sunday, they came in and started painting, they tore up the kitchen, they changed off, they did all this stuff, and then our stuff is in the house. They were like moving our stuff together, and it's like, screw you guys. It's been terrible.
I don't know why I'm not thinking of any other nursing intervention. And maybe you're thinking just meds. Maybe that's what I was. Yeah. Yeah, I'm sure.
All right.
All right. Traumatic brain injury, that's the last little part. It should only take probably 10, maybe 15 minutes. But traumatic brain injury, remember we talked about spinal cord, and that's the actual spinal cord. That's how it's different than an actual head trauma. So most of the time when you get a traumatic brain injury, you're going to have it basically from a blunt blow to the head, a potential fall in the elderly, or a motor vehicle crash. Those are things that we look for. What are some signs that we actually have a head trauma problem? What's the biggest one? Level of conscious changes or loss of consciousness. They actually get hit in the head and they lose consciousness, they have to come in and get evaluated. Because over time, they could potentially increase their intracranial pressure and they could die. And that's why people actually die. Maybe the stubborn football player that's in high school or college, he may have had a concussion and didn't even know it. And he might get repeated blows to the head and increase that intracranial pressure. And those are the people that go to sleep and don't wake up. Okay? Or elderly people that have epidural hematomas because they fall and hit their head, hemorrhagic bleed, and they potentially die from that increased pressure. Okay? So things that you can potentially see, obviously loss of consciousness, amnesia, they might have memory loss. It could come and go, depends. A severe headache. If they have a severe headache, that could potentially mean an increased intracranial pressure. Nauseous and vomiting, like that. What else? Pupil changes. We always assess pupil. We want to make sure perla is intact. They're actually assessing pupils. If they're severely dilated, that is a clear-cut sign of intracranial pressure increase. Okay? Our constricted pupils are bad too, but dilated means intracranial pressure increase. Dilated. Yes. Really, really bad. Okay? Potential problems too, if you think about a blunt blow to the head, let's say it's an open injury, what kinds of problems can you think of with open injuries? Infection for sure. They potentially might have meningitis, cerebral spinal fluid leaks. And so we would look for that on assessment like nuchal rigidity, meningitis. You can do the Brodinski sign or the Kernick sign. And I have that, put that on the PowerPoint, but it's just when you raise the head up of your neck, your knees will come forward. That's Brodinski sign. What's your point? Just means your neck is really stiff. That's all it means. Kernick sign is when they lift your leg up like this, and they can't actually bend your knee because it's so stiff. Your hamstrings are really tight. You experience a lot of tightness in the body, and that can be a sign of meningitis. Okay? Significant fractures, we talked about open and closed. Obviously open, I hate to say it's better, but a closed head fracture, the pressure inside the brain can become worse because there's nowhere for it to go, or a potential hemorrhage or hydrocephalus, depending on the type of injury. But open injuries have a high risk for infection and potential exposure of that tissue. Okay? They're both bad, I'd say closed is worse. Okay? What about basilar? We talked briefly about that fracture. Remember that one?
Yeah, the breathing higher.
That's the one that's like right behind the nose, and it can affect your a lot of your cranial nerves in that spot as well. If you look for the raccoon eyes, literally what it's called, and battle sign, which is behind the ear. So let's say this happens quite a bit in elderly. I think a head injury for a motor vehicle accident, we suspect their head has been hit, so we're looking for these signs. But what if elderly people come in, they have long hair, and they may have fallen a couple times at home, didn't know it, and they come in for something totally unrelated, and we're assessing them, and all of a sudden we see a little bruise behind their ear. Happens a lot, because they're falling at home and not telling anyone. And they come in, we actually do a CT of their brain or their head, and we see a small basilar fracture. Happens a lot. Now let's say we didn't know that. They didn't come in for head trauma, they came in for brain weakness, I don't know, something unrelated, and we think, oh, they have to eat in 6 days, we have to put NG tube in. That could potentially happen. That does happen, you guys. You might think, well, why would I put an NG tube in someone that got their head hit hard when they were on a motor vehicle accident? I'm talking about things that are subtle changes. This could definitely be a problem. We look for cerebral spinal fluid leak with these people. So there's clear drainage coming out of the nose. We put that on a white tissue paper, and we'll see that yellow ring called the halo test. So halo test is what we would look for with cerebral spinal fluid. You can also test it for glucose. Glucose is not as indicative of a cerebral spinal fluid leak. Sometimes glucose can be in every tissue in your body. But we suspect halo, the yellow ring, that will be prominent. Okay, let's talk about intracranial pressure changes. This will be a big part of this exam, I feel like. How do you know someone's intracranial pressure is increased? Okay, you can do the pupils being dilated. We talked briefly about that. What about activity of the patient? First of all, level of conscious change. If you suspect they're getting more restless or they're more confused, they're irritated, that's something we're going to look for too. Level of conscious changes. What about ABG? What can make ICP monitoring worse? Or ICP measures? Carbon dioxide. Your CO2, let's say, is 50 or 60 when they do an ABG. What could that do to your intracranial pressure? Increase. So if your CO2 is high, actually works as a vasodilator, and that can make it worse, or your intracranial pressure changes. So ICP goes through the roof. So these people that we usually have intracranial pressure changes that are really severe, they're ventilated or intubated and on a ventilator, and we will put their hyperventilation state up, right? We want to blow that CO2 off. So they will be on a hyperventilation ventilator, okay? You can do that, or you can increase their pressures or their tidal volumes to help them take deeper breaths to blow it off. That's one option. We're bringing back respiratory, nothing's on it. Okay? So ICP monitoring, normal is less than 15, like what we like to see it. What would you do if the pressure was 20, 25? What are some things that you could do? Okay, elevate head of bed. We like to see it above 30 degrees. You can elevate that. We always want to keep neck in neutral spine, no matter what height the bed is at. But we do not like to see it less than 30 degrees. That's your magic number. Okay? Let's say medication-wise, what could we do for ICP? Mannitol is going to be your number one we'd use. That's the commercial. How does mannitol work? The osmotic diuretic. So it's going to take that fluid off the brain. You're going to pee it out. Where you're going to find it. So INO is essential. Okay? Not that it's going to increase tremendous amounts. That's where it's going to excrete. Vital signs, we could look at that, but that's not going to tell us exactly how mannitol is working. We might notice that they become hypotensive because they're getting rid of a lot of fluid. But the way we know mannitol works is if they're improving, right? Their ICP monitoring is coming down, their ICP level, and if their level of conscious increases. If they're getting less restless because they're on mannitol, great. That is doing its job. Your level of conscious change is improved. Okay? You could give LASIK, that's another one, but it's not as showing effect on the brain. That's more for fluid retention inside the body. So it could have some effects, but not a lot on the brain. Yes, ICP. Yep, and Yep, so these are things that we might do before we actually put in an IC catheter, okay? So these are things we might be able to do for like slight changes in ICP monitoring, like 20. But if someone is really high, we have to go in with a catheter and drain out the fluid, okay? Or a craniotomy might have to happen to release that pressure in the brain. So when we have our ICP monitoring significantly in the 20s to 30 range, and it stays there, we might have to put that little catheter in the brain. It has a transducer, remember? That's what is on the tragus of the ear. We have our little transducer that's level with what's with your ear and with the tragus nerve right in the middle. Okay? So this little thing is like a pole. And this little guy here will be connected to a hole in the brain. I should put a hole in there so there's a chance for cerebral spinal fluid leak. And it drains that fluid off the brain. There's a little thing down here, and they have to change that out. So you'll actually get cerebral spinal fluid in a little canister. You get to see what that looks like. Okay? What do you think it looked like? Clear, kind of yellowish. Okay? If it looked pussy or any type of bloodiness, that's not normal. You have to notify the physician. But yes, the transducer has to be at the side to take that off so that if you go too fast, you can cause more problems as well. This keeps it so you do not get too much different pressure changes in the brain. Okay?
That's how you
Get rid of.
that's how you monitor it. It's by
Yes, you can measure it through there. But they can have those little screws. Remember I told you it's just like it has like this. It comes out in a little thing. Okay. That can measure ICP monitoring only without the drink. Yep. And that has a less risk for infection. I wouldn't focus too much on that part. I'm not going to get too hairy with knowing the difference between those two things. But just know that if your ICP is really high, they have to have a drain. Okay? They have to get rid of it. Yep, that's when you put the transducer on, because it's connected to that catheter. Okay? Let's see, what else could we do for ICP monitoring? Yep, that's covered. Yep, that can be a sign that will be Cushing's triad. If you see posturing, that could be an indication. So the therabit and the decorticate. Decorticate, remember, they're going to the core, and they usually look like they're having C's for hands. They'll actually extend their feet. They'll extend their feet out, but they'll be forward. With these therabit, they'll actually push out their arms, and they'll be completely extended everywhere. Okay, this means that there can be increased cranial pressure. Okay. The Cushing's triad, that's a good one. You'll notice, and if you come to my review on Sunday, and I'll release that PowerPoint that I give out, but with Cushing's triad, vitals, again, there's a lot of things we have to memorize for what vital signs go with which. Notice that, okay? It can be really hard to distinguish or to verify which one is the appropriate one. So there is a couple on there that I put for the review. You guys can know which ones are which. But by then, you should probably know most of them. Right? So with Cushing's triad, what are you going to see? High blood pressure. What about respiration? Decrease. Only as high as your blood pressure. Okay? So Cushing's triad, this can be something that, let's say they come in with a head trauma, head injury, and we notice that these blood pressure is very high and heart rate is low, those respiration. You can suspect that you have intracranial pressure increase. Okay? There's so many signs of intracranial pressure increase that you might say, I don't even know if it's really increased or they're just having this problem. Okay? You might not. There are some significant ones that you might see repeated if you work inside a neuroacute hospital. But these are things that we teach you just to kind of show what you see inside those neuroacute hospitals. Some nurses might say, big deal, dilated pupils. They probably won't even think twice about it. But those are showing that increase in intracranial pressure. Epidural and subdural. I would say focus on epidural and subdural more than the intracerebral. Just know that if they're having level of conscious changes and potentially from a fall or hit, they could be having those problems. Epidural is faster, usually happens within the first hour. Subdural can wait longer, it's a slower bleed. Yes, epidural, you'll come in and out of consciousness. So usually they'll maybe fall, hit their head, or lost consciousness. come back, nothing's wrong, they feel great, and all of a sudden they lose consciousness again. That's significant with an epidural hematoma. And that can cause intracranial pressure change as well. You're bleeding. Actually, hemorrhaging the brain. Any type of fluid shift, edema, anything can affect intracranial pressure. That's why we talk so much about it, because that's the first sign you look for. And it's the best sign to look for. Talk about meningitis. I'm not going to touch much on electrolytes. Remember the diabetes insipidus and the SIADH. Know that you do have electrolyte problems with maybe the shift in the brain, but I expected you to know that for Unit 3 of last semester. I'm not going to test over that again. What's that? Yep. It depends on the brain. Say if you have a pressure on that pituitary gland, you can have problems with DI and SIADH. Maybe know briefly, remember DI, you pee out a lot. That's why you get dehydrated. With SIADH, you retain a lot, so you have fluid volume overload. So think about that as a basic. I'm not going to get too specific on the exam, or you can test about that. Okay, I don't want to waste. Okay, I'll touch briefly on brain tumors. We didn't talk about that today in class, but I think that's all you really need to learn traumatic. So brain tumors is pretty, another reason why I didn't go over it is because I feel like it's pretty self-explanatory. You have a brain tumor inside the brain, it's obviously going to push on your tissues inside the brain, and that can cause intracranial pressure changes. It'll actually increase the pressure from that swelling inside. Most brain tumors, if they started in there, most of the time they don't travel anywhere, okay? When you have metastasis to the brain, it's usually because you had a primary problem in a different organ, like a lung or kidney, depending on where your cancer was at before. So if your primary tumor comes from the brain, it usually doesn't go anywhere else. With the brain tumor, we will look at radiation, chemo, but the best thing is taking it out by surgery. So they will have craniotomies. Okay? Most of the time, I'd say 90% of the time, chemoradiation can't do it well enough. They have to go in and extract. Okay, so think about craniotomies. What's that? Right, radiation right in the brain is not the best thing because it can have a traumatic effect on the other parts of your brain. So you might lose hearing, vision, different parts of your sensory and motor for sure. So that's why they try not to use radiation. If you're going into the craniotomy, what's your highest risk? Infection. So brain tumor people will have a high risk for infection. Cerebrospinal fluid leak, that's also a potential. So you'll look at the halo test, testing for glucose. These people might be on ICP monitoring. They probably will. So they'll have that transducer, same kind of thing. They'll be in ICU for quite a while until they're back to their normal state. They could potentially get mannitol as well, make sure they're getting rid of the blood pressure. What are some things, I know you haven't looked at it, but for assessment, that you might potentially see in a brain tumor? Anyone go ahead? Okay, so I'll tell you that one. So for assessment, first thing people complain about when they have a brain tumor, significant one, is headache. Yep. Headache is going to be the first thing you see. And a lot of people don't think anything of a headache. Tell it's every single day. Severe enough, it might be causing other problems like nauseous vomiting, excessive blurry vision changes. Okay. Talk about vision. Vision changes. It's obviously pushing on what nerve? Optic nerve. Right. What's that? Yep, so you can have tingling or sensory motor changes. If it pushes on side other nerves, you might see those problems as well, like hearing loss. Seizures. You might just have a random seizure. You're like, what the heck? I've never had a seizure in my life. That could be from a brain tumor pushing on and causing intracranial pressure changes. So think about medications. What medications do we give for seizures? Like Dilantin. That's the one I'm going to test over. Okay. The Dilantin, we look at levels. We want to make sure they're normal, making sure that we don't give pills during an actual seizure, giving the medication appropriately. Loss of consciousness or level of conscious changes. Sometimes they'll have confusion. They're starting to get dizzy. Those kind of things. Apoedema. You guys heard of that before? Nope. That's I can't think of that one called. That's when you get goosebumps below the level of autonomic. But this one is just an optic nerve swelling. You can have swelling on the optic nerve. Makes sense because you're pushing up on certain things that's causing blurred vision. Here. Yep. That's pretty much it. We can notify how we're going to get one of these changes by a CT, MRI, is going to show us the actual grade. All right, any questions or anything you want me to go over before we're done? Or you feel like you're just not getting something? You're like, what? Where is this question going from on the blueprint? Okay, if you think about, I can think about that as an acronym. Right, remember how I told you in spinal cord injury that back pain was the #1 problem in the United States, or the #1 visit where they come into the doctor's office? It's basically, for that question that you might see on the exam, it's talked about as a whole of pain control. Not necessarily for specific disorders, but what they might experience and what alternative things we can do for pain, starting off with the less severe and working your way up. Some people truly do need severe opioids. I do believe that for like brain tumors can be painful. I do agree with that. So we probably would give Tylenol, something simple. We probably would give something more severe. What is it called? Trigeminal neuralgia? Yes, that's the one. We do not give NSAIDs or opioids. Yes, NSAIDs are opioids for that. I'm thinking about those types of medications. But everything else, we give those. Trigeminal neuralgia is the one with the nerve. Trigeminal. No NSAIDs or opioids. I guess we didn't talk about that. That was a purple. Yeah, I feel like I think it's a clicker question. It's a clicker question.
I just remembered the question.
Yep, clicker questions. I know Hannah had made a good point when we were going through them in class. She goes, man, I'm going to do awesome on the exam if there's this. I said, that's because you just learned about them. Wait 3 weeks, and we haven't talked about spinal cord injury. Go back to your clicker questions, and you're going to say, I don't really know now because I forgot them. So that's why I put them on TigerNet so you can go through them again and now kind of assess what you've learned in the answer. I highlighted in the red.
My brother has this kid broken back while riding, and I keep asking my brother, like, oh, how are you doing? Like, what happened?
Yeah. Jess Peters had a kind of a cool story. She was working down Wagner and just left, and they had a, what was it, C7? C6? 5? They flew him out for Sioux Falls, which he was fine. It must have been a minor fracture, but they did fly him out, and it does happen in real places. So you don't have to work in a neuroacute hospital to see this stuff, you guys. You're going to see it first line on the smallest hospital in South Dakota. Those are big. All right. I think I'm just going to go buy a 10 energy drink. You're going to what? I'm going to go buy like 10 energy